A very good morning to one and all. Today we have Dr. Shubha V. Hegde with us. Dr. Shubha V. Hegde is MBBS, MD, DNB Anesthesiology, FIAPM, CCPC, and EDPM Part 1. Dr. Shubha is working as a consultant pain physician at Alleviate Pain Management Centers, Bengaluru. And I'm very happy that she agreed to talk on this mystical topic today, which is hip mysteries solved. So, hip pain can have a lot of differential diagnosis. So, today we will be trying to explore that and try to find out what exactly could be the different causes and the solutions for such problems. So, over to you, Dr. Shubha V. Hegde. You can start your presentation now.
Thank you, sir. Good morning, everyone. First of all, I would like to thank Dr. Javed, sir, for giving me this opportunity. So I'll be talking about uncommon presentations of HIP today and their solutions. I'll be discussing the topic under few headings like case scenarios, history examination, etiology of the particular problem, investigations, and management. Coming to first case scenario, I wanted to be interactive, so feel free to answer. I'll be sharing few case scenarios. So if you can do answer about the differential diagnosis. So scenario one, a 46-year-old male presented with pain in front of the hip, that is in the groin region, which was insidious in onset and gradually progressive in nature. Dull aching increases on sitting, running, climbing stairs, playing sports, which include sprinting and kicking activities. This pain is there since 3 years. Pain is associated with restriction of movements at the hip. Pain also radiates to anterior thigh sometimes, and sometimes to symphysis pubis, and sometimes to the lower back and buttock. He used to play badminton almost every day. He was a very active person, but now he's not able to play regularly since last 3 days. Pain started initially on the right side, slowly started on the left groin as well since 1 year. No comorbidities, no history of fall or injury, no history of steroid use. On examination, there was restricted internal rotation of the hip and adduction at both the hips. MRI and X-ray both were normal, but have been taken, but the report is not disclosed here. It is not normal. Patient has visited many orthopedicians, and they have suggested only physiotherapy till now. So what do you think it could be? Anybody?
Ma'am, is it related to psoas?
No, can be one of the differential diagnosis. Sorry. Any other thing which you can think of? Pain with restriction of movements. So it can also be, this case is femoroacetabular impingement, also called as acetabular rim syndrome, also known as cervicoacetabular impingement. So let's talk about this. One of the differential can also be, as she said, so related to the muscles as well. What is femoroacetabular impingement? It is nothing but a hip pain which is caused secondary to a mechanical impingement from abnormal morphology. As you can see here, hip joint is usually formed by acetabulum and the femur head. So if there is a mechanical impingement because of the abnormal hip morphology, that is because of acetabular outgrowth or excessive coverage from the acetabulum, this is normal, which is, this is the acetabulum and this is the head. If there is an excessive coverage or the extra growth, okay, so which is an abnormal morphology, this can lead to impingement of this. Whenever the hip joint moves, then there is impingement of the soft tissue around this. And as well as the other form can be, there can be a growth at the femoral head and neck junction. So this is the abnormal morphology at the hip joint. This both can result in something called as femoroacetabular impingement, which can lead to hip pain. With every hip rotation or with every hip movement, the pain and stiffness can aggravate. So coming to types of femoroacetabular impingement, there are three types. One is the pincer type, where there is extra growth of the acetabulum. Other one is the cam type, which is nothing but extra femur. The other is the combined form. Coming to signs and symptoms, as I already told, they with groin pain, and more pain, there is a lot of stiffness at the hip joint. They also have a limp when they present to the also limp. So, and there is sometimes radiation of pain to anterior thigh or symphysis pubis or to the ipsilateral testis men as well. And they also come, some people also come with low back pain. So how do you assess them? So clinical examination wise, we have to check for any impingement. So there are few tests, whether there is an anterior impingement or a posterior impingement, you will get to know by doing certain examination. Like this is forceful internal rotation with hip flexion. With the hip inflection, when you do forceful internal rotation, if there is an anterior impingement, the patient will feel pain and you will get the restricted movement as well. And with the forced external rotation, with the hip inflection, you can feel the posterior impingement. This is also called as Dremen's sign. And the other test which you can do is in patient with lying down and with maximal extension, we have to do a forced internal rotation. So this also gives rise to pain and restriction at the hip joint movement. The other test is McCarthy's test, which is same, the forceful internal rotation and external rotation is checked, but in a different method. That's all. There is this, when you can see there are two types of, when there are two types of morphology abnormality, we can find certain differences amongst them. Coming to the differences, whenever there is a pincer deformity, we can see the acetabulum, as I already told, the pathoanatomy is the acetabular overgrowth, excessive growth at the acetabulum. And at the cam deformity, when you see, there is a excessive growth at the neck, femur, head and neck region. Mechanism is repetitive trauma because of the, like as I told, involvement in sports, or it is more common in athletes as well, and those who are very active in the sprinting and kicking activities. So all of them can result in the pain, and it's more common in male when compared to female, and presentation is usually in early and late mid age. That is 40 to 50 years in case of pincer deformity, and early middle age in case of cam deformity, that is around 20 to 50 years. The other distribution of cartilage damage, once there is a deformity at the level of hip joint, whenever the movement occurs, the hip joint cartilage can also get damaged, which ultimately leads to hip osteoarthritis. So this can happen in both of the deformities, but the region of cartilage damage differs because of the overgrowth. So other associated disorders can be, one is because of the trauma, post-traumatic malunion. If there is a fracture and there is a malunion at that site, this can also further lead to, because it's a morphological abnormality, this can also lead to femoroacetabular impingement. And a proximal femoral focal deficiency or Perthes disease or any other like rickets or developmental dysplasia of hip and other iatrogenic causes like surgeries also can lead to, and it can be congenital because sometimes they can have a retroverted acetabulum, so which can also lead to this pincer kind of deformity. Late and early mid age. Till then, it will not cause any problem. So other differential diagnosis, what all can you think about when they come with groin pain is, one is very common, that is if they're coming at 30s or 40s, you always suspect avascular necrosis of femoral head, because they also have antalgic gait, pain, and stiffness when sitting. So other causes, hip dysplasias, and other cause, as she mentioned, it can be iliopsoas tendinitis as well, and a greater trochanteric bursitis in the lateral region, but the pain also can come to the groin. There can be gluteal tendinopathies, so which may present in the similar way. And there can be arthritis, there can be arthritis of the hip, but femoroacetabular impingement in later stages can also present with hip osteoarthritis. And iliotibial band syndrome can also present this way. And there's another entity called a snapping hip syndrome, which I'll be addressing it later. So that also can be one of the reasons. And the other reason is, always whenever a patient comes with hip pain, we have to examine low back. And it's vice versa. Whenever a patient comes with low back pain, we have to always examine hip pain, because the structures have chemical attachments to both the bones. So they can mimic each other. So other causes can be infection. What investigations we can do is, we can find out by doing an X-ray and an MRI. MRI is highly sensitive. It's the investigation of choice for femoroacetabular impingement, because we can also get to know about the soft tissue, what is impinging, and what is the grade of arthritis also can be known here. And we can also do a CT scan, where it tells, they usually, orthopedicians will require it if they're going to operate these cases. So coming to management, it's one of the conditions which is difficult to diagnose, and it's difficult to treat. I had a patient who came with femoroacetabular impingement. Actually, it is his history only. So when he came to me, it's already been almost 2 to 3 years. So he has visited many orthopedicians and doctors, but they always had told him to just do physiotherapy. And now it is not the stage for surgery. But still the pain and stiffness kept on increasing. So he has taken pharmacotherapy like NSAIDs, muscle relaxant. It will help only for a limited duration of time. And physiotherapy can sometimes, it is one of the management option, but sometimes it can trigger the stiffness as well, stiffness and pain as well, because already the muscles and tendons there are very taut. So, but hot pack compression for a short duration can improve the spasms around the hip joint. And as pain physicians, we can also think of interventional treatments, like if there is a hip osteoarthritis which is setting in, early hip osteoarthritis, we also plan for intra-articular viscosupplementation, which gives the patient a bit of relief in movements at the hip joint. We can also plan for prolotherapy of ligaments and tendons surrounding the hip. So this also can result in stretching. Basically, whenever there is unstable hip, it results in, the prolotherapy results in stabilizing the ligaments around the hip. So this also can be tried in patients with femoroacetabular impingement. In fact, I have given intra-articular viscosupplementation as well as prolotherapy to my patient, and he has improved. Now, prolotherapy, 5 sessions I have given with the 12.5% dextrose, and intra-articular viscosupplementation was 60 mg. So as you can see here, this is how we did intra-articular viscosupplementation. That's using ultrasound guidance. So this is what I had done for my patient. As you can see here, intra-articular viscosupplementation will also help them in movements and doing their physiotherapy better. So physiotherapy is the mainstay of treatment in femoroacetabular impingement. And if the deformity is really increased and the stiffness is more, he is not able to move even after the interventions, the ultimate treatment for this is surgical treatment, because it's a mechanical obstruction and it's a mechanical abnormality which is there, which is leading to hip pain. So this, the surgical options being arthroscopic shaving of the deformity. And if there is osteoarthritis, which is of higher grade, then hip replacement is the only option left. So these are the ligaments which we target when we do prolotherapy. Not only the ligament surrounding the hip needs to be addressed, but also the ligament surrounding the sacroiliac joint needs to be addressed, because there's a lot of instability which is caused because of the deformity at the level of low back as well, at the level of sacroiliac joint region. Whenever there is flexion and extension at the hip joint, at that time there is a strain which occurs at the SI joint as well. So prolotherapy around the SI joint with prolotherapy around the hip joint will definitely help in the mobility, help the patient in doing their physiotherapy, and also improves the mobility. So my patient had, after 5 sessions of prolotherapy and 1 session of intra-articular viscosupplementation, he had around 60 to 70% of pain relief, and his mobility also, the abduction and flexion and adduction which he used to do, all the movements improved at the hip joint. So these are the ligaments which we need to target. And there's this paper which also states that there is a case report where the prolotherapy was done with polydeoxyribonucleotide sodium. That is nothing but it is a linear polymer which is derived from the gonads of the sea fish, that is not salmon fish. So what does this polydeoxyribonucleotide sodium do is, it acts as an anti-inflammatory agent. Also, it helps in angiogenesis. So this helps in healing as well. So when they used it in this ischiofemoral impingement syndrome, so the patient had a good relief of pain as well as improvement of movement at the hip joint. Coming to the second scenario, so there's a 28-year-old female athlete who presents to the OPD with complaint of popping sensation in her hip when she walks or exercises. So she describes that snapping occurs mostly when there is transition from sitting to standing position, or during certain movements like running, climbing stairs. The sensation is mostly painless, but occasionally accompanied by discomfort on the outer part of her hip, okay, especially after a long day of training or doing training or running. On examination, there was a noticeable snapping sound which was heard over the outer lateral aspect of the hip when flexion extension of the hip was done. Palpation of the greater trochanter reproduced the snapping sensation or the sound, the popping sound. Patient reports, when this snapping happened, the patient reports localized tenderness. There's no significant limitation in her range of motion, and strength testing was normal, no motor deficit as well. So what do you think it could be? Any guesses?
Snapping hip syndrome, you told.
Yes, correct. So it can be a snapping. It is, in fact, a snapping hip syndrome. So it's also called as coxa saltans. So what a snapping hip syndrome is, it usually involves snapping sensation or sound in the hip during the movement, either flexion or extension of the hip joint. And it occurs due to the tendons or muscles or ligaments which move against the bony structures in the hip. So when I say tendons or ligaments moving on the bony structures, which is the most common thing you can think about? The most common tendon. Any guesses? One was mentioned already in the case scenario. Okay, so I'll be mentioning it later. So it is commonly seen in athletes, dancers, and in individuals who perform repetitive hip motions. The most common which you can think about the tendon is the iliopsoas tendon and the iliotibial band. There are types of there are types of snapping hip syndrome where depending upon where the snapping is happening or depending upon where the movement is happening, it is classified into 3 types. That is, one is external snapping hip, which is caused by the IT band or any gluteus maximus tendon, medius or maximus tendon, which is snapping over a bony prominence, that is greater trochanter. And it's common in runners and cyclists, as I told. And internal snapping hip, actually the scenario was external snapping hip. And internal snapping hip can also occur where the patient tells that somewhere inside he or she feels the snapping occurring or the popping sound. Occurs when the iliopsoas tendon snaps over the structures in front of the hip, that is iliopubic eminence. So it is most commonly seen in dancers or athletes with repetitive hip flexion. Another entity is intra-articular snapping hip, where the defect is inside the hip joint. So the pain they complain is also deep inside. It is not superficial. It is not on the outer side or inner side. Rather, it is deep down the hip joint. It is caused by some certain labral tears, certain kind of conditions like labral tear or loose bodies due to the osteoarthritis. And it is less commonly, this requires surgery. Sorry, it is less commonly seen, but whenever this occurs, it requires surgery. So coming to external and internal snapping hip, as you can see here, this is the iliotibial band, and this is the greater trochanter. Whenever the movement happens, so there is the snapping of iliotibial band over the greater trochanter. So this leads to an unstable hip, basically. So, and at the level of snapping, there can be friction, and this can lead to the bursa formation or bursitis at this level. So internal snapping hip, as I told, there is this iliopsoas tendon, which is flipping over the iliopubic eminence. So symptoms, as we already saw, there can be snapping or popping sensation during the hip movement. It occurs during the activity like walking, standing up, or rotation of the hip. And initially they come with some kind of discomfort. But later, whenever there is bursitis which is formed, or there is tendinopathy which has already occurred, then there is pain. There is chronic pain with that. And they also come with tightness and tightness or weakness of the hip muscles, depending on the presentation. And they also complain about the restriction of movement at the hip joint. So differential diagnosis which we can think about is for intra-articular pathology or intra-articular snapping hip, it can be loose bodies, femoroacetabular impingement, or a lax capsule, or ligamentum teres rupture, or any chondral injuries. So for extra-articular, we can think about iliopsoas tendinitis, trochanteric bursitis, gluteus medius or minimus tear, or a stress fracture, or piriformis syndrome, which also has an attachment at GT. And sacroiliac stress syndrome can also be one of the differentials. As I already told, they have interconnections between them anatomically. So coming to management part, initial management, when there is only popping and the discomfort, it is rest and activity modifications and we always have to suggest them to avoid the repetitive movements or the aggravating movements which they usually do. Okay, so the second thing is physiotherapy. We have to ask them to do stretches and strengthening exercises of the hip muscles, because the main problem with snapping hip is an unstable hip. So physical therapy will help in improving the flexibility as well as to give the stability at the hip joint. So pharmacotherapy, if there is a lot of pain whenever they come with tendinopathy or bursitis, we can always ask them to use the ice pack and give NSAIDs. And as an interventional pain physician, yes, we do have a role in this. We can give a corticosteroid injection at the site where that is at the bursitis region, or any tenosynovitis which has occurred at the region of the snapping. There we can give ultrasound guided steroid injections. Or if there is a tendinopathy, if it is a long standing snapping hip, we have to concentrate on improving the stability around the hip joint. So prolotherapy again is one of the good options in bringing back the stability of the hip joint. So if there is an intra-articular pathology or intra-articular issue, surgery is always the option. And if conservative treatment fail, then surgical option has to be used. Like in tendinopathies, if there is a gross tear. Okay. So these are the bursa which can occur. So just beneath the iliotibial band, there is two bursas which are there, which I'll be talking about later. So because of the chronic friction, there can be development of bursitis, and also at this region. So prolotherapy, where to address? So we have to always address the iliofemoral ligament, pubofemoral ligament, and ischiofemoral ligament during the prolotherapy, and also to the sacroiliac joint ligaments posteriorly. So coming to the third scenario, a 45-year-old female presents to clinic with chief complaint of persistent pain at the outer part of her right hip. She describes the pain as she describes the pain as a deep aching sensation that has been gradually worsening over the past few months. Initially, pain was mild and occurred only after prolonged periods of standing and walking. But now it is even present at rest, particularly when she's lying on the side on the same side at night, which disturbs her sleep. There was no history of trauma or injury, but she mentions starting new exercise routine several months ago, include running and stair climbing. And there was also stiffness in the morning, which improved after moving around. Medications, but relief was minimal. On physical examination, the palpation over the greater trochanter, that is the outer part, LSC, with the posterolateral aspect. Pain is reproduced when when the hip abduction and external rotation is resisted. But there is a discomfort with the active movement. No obvious weakness or signs of hip joint instability, and the neurological examination seems to be normal. So can you think about any conditions which is causing this? Sorry? Am I audible? Hello, am I audible?
Yes, audible.
Okay. So can anybody think of any conditions similar producing this? Okay. This comes under an entity which is called as greater trochanteric pain syndrome. Here, it might be a bursitis or a tendinopathy. So this condition is very common, but the diagnosis is often missed. Why greater trochanter palpation is very important in hip joint examination is there are a lot of tendons which are attached, and tendons and muscle which are attached around the greater trochanter. As you can see here, there is hip abductors, that is gluteus medius, maximus, minimus, and vastus lateralis, quadratus femoris, conjoint tendon of iliotibial band, and fascia that is attached here, and the piriformis is also attached here. So any tendinopathies of these tendon can lead to a painful greater trochanter. So we have to investigate further and examine further to know there is the iliotibial band syndrome also comes under this. So we have to examine and find out what is the cause for the pain at the greater trochanter. So as you can see here, there are facets which are there for the greater trochanter. That is why it resembles the rotator cuff. It resembles the shoulder actually. So this muscles around the greater trochanter at this region actually is called as the rotator cuff of lower limb. So there is a facet, there is anterior facet to which the gluteus minimus is attached, and the lateral facet to which the gluteus medius tendon is attached. So any abnormalities in them can lead to pain at the greater trochanter. It is a clinical diagnosis, as I have told. No much investigations will not lead to much further solutions, but clinical examination clinches the diagnosis. So it is a clinical diagnosis of lateral hip pain, which includes trochanteric bursitis associated with tendinopathy of like gluteus medius or minimus tendinopathies, or tear at the gluteus medius or minimus, and also external snapping hip syndrome can also be one of the cause for it. Patient usually complain of pain over the outer aspect of the thigh, and it is usually as I have mentioned in the case scenario, it usually occurs when the patient occurs in the night, when the patient tries to sleep on the affected side. So whenever patient is climbing or person is climbing stairs or sitting for a long time or involved in high impact physical activities, then the pain is severe. Usually affects females of 40 to 60 years of age group. Main bursa that are associated are the gluteus minimus, subgluteus medius, and subgluteus maximus bursa, which are the reasons for pain around the greater trochanter. Earlier, the bursitis was thought to be the main cause of greater trochanteric pain. But recently, tendinopathies are the root cause for greater trochanteric pain syndrome, because tendinopathies will result in bursitis. So any changes in the tendon, tear or strain can lead to bursitis because of the friction. So etiology, as I mentioned, tendinopathies, trochanteric bursitis, iliotibial band syndrome, and any biomechanical issues with the hip, like weakness of the hip abductors, like gluteus medius and minimus, overuse or trauma or repetitive stress, age-related degeneration, and systemic conditions like rheumatoid or inflammatory arthritis, and certain leg length discrepancies. Any deformities in the hip can also result in this GTPS. So diagnosis, how do we diagnose this? There are different signs. One is direct palpation at the greater trochanter. If there is bursitis or the region is severely inflamed, then the patient can have jump sign, what is called as jump sign. That is, directly when we palpate, the patient also jumps in pain. The single leg stance test, that is, whenever the patient stands on the leg which is on the limb which is painful, within 30 seconds there is pain at the side. This is highly sensitive. And also Trendelenburg test to check for the hip abductor weakness. Faber test or flexion abduction external rotation can also also checks the hip pathology, and flexion adduction external rotation also checks for the hip pathology, and flexion adduction and internal rotation can also check for piriformis. And passive hip adduction on the lying side can also mimic the pain. Like whenever we passively adduct on the side lying where there is pain, so it can reproduce the same kind of pain at the outer part of the hip. There's other test called as Ober's test. This is for iliotibial band stiffness. So what is it is, patient is, as you can see here, the patient is lying on the normal side. It is the unaffected hip side, and the affected hip is on the upper side. So the examiner stands behind the patient and asks the patient to flex the knees, and he abducts and externally rotates or extends. He abducts and extends the hip. So if the iliotibial tract is stiffened, the abduction of the leg is very painful, or abduction at the hip joint is very painful, and patient will resist the abduction. So this means that the Ober test is positive. This suggests the iliotibial spasm of the iliotibial band. And the Trendelenburg gait, this is for testing the weakness of the gluteus medius and minimus, that is the hip abductors. So when the patient stands on the affected side, so this normally what happens is, when the patient stands on one leg, what happens? The gluteus medius and minimus of this leg tries to stabilize, of this hip tries to stabilize the other hip, so that the pelvis doesn't drop down. When the same person, if there is when in the same person, if there is gluteus medius and minimus pathology or weakness, if the patient stands on the affected side, what happens is there is no compensation which occurs. The sound side always sags down, because because of the pathology, it is not able to abduct the pelvis or abduct the hip. So the level of the pelvis is not maintained. The sound side always sags down. Coming to investigations, we can take the help of ultrasound. So whenever the pathology is, whenever you identify a pathology by clinical examination, we can confirm certain diagnosis by doing investigations like ultrasound and MRI. Ultrasound will tell us, this is the greater trochanter, and this is the bursa which I was mentioning. This is the subgluteus medius bursa. This is the gluteus medius tendon. This is the gluteus maximus tendon. So this is the trochanteric bursa between maximus and the medius. So this is the anterior part of the greater trochanter. This is the posterior aspect of the greater trochanter. So these two bursas can be there. So whenever we keep an ultrasound, that is the curvilinear probe, since the structure is deep. Some may require linear probe if the patient is lean. So this, if there is a bursitis, we can find it out through ultrasound, and we can do ultrasound guided injections as well. For tendinopathies, if we are suspecting tendinopathies, we can always go ahead and do MRI scan. Coming to management, the conservative treatment is the first line of management. That is activity modification, which includes rest and avoid lying on the same side. You can also give ice compression and pharmacotherapy like NSAIDs, and stretches, strengthening, and soft tissue mobilization and gait training in case of hip abductor weakness can also be one of the management options. And taping and braces can also be given. So this indirectly gives rest to the area. Taping indirectly gives rest to the area, and the inflammation reduces. So then slowly the physiotherapy, stretches, and strengthening can be started. Interventions which can be done are corticosteroid injection. Like if there is bursitis, as I already told, we can do a bursa injection. And tendon sheath, if it is inflamed, okay, if there is a fluid accumulation, we can always do a tendon sheath injection. PRP and prolotherapy have also shown beneficial in case of tendinopathies. So if there is a partial tear, or if there is a partial tendinitis or any inflammation, we can also treat with platelet-rich plasma therapy and prolotherapy, which initiates healing in those tendons. So this results in improving of symptoms, but this takes this usually takes little time, like a few months for it to recover, as these are regenerative treatments. So we have to also advise for lifestyle modifications in them. Coming to last scenario. So a 52-year-old male presents with an 8-month history of localized burning and tingling pain over the right posterior iliac crest, that is in this region. Okay, pain worsens with sitting and bending or any rotation of the trunk, but improves with standing or walking. He denies any leg pain, weakness, or numbness. Previous treatments like physiotherapy and NSAIDs provided little relief. Physical examination suggests there is tenderness upon palpation over the posterior iliac crest at this region, 7 to 8 centimeters from the midline. So full range of motion in the hip and lumbar spine through, though the lumbar flexion provokes discomfort, but there is no restriction of movements at the hip and lumbar spine. There is no neurological deficit as well. So what do you all think about this case? Sorry? Sorry, I did not, it was not clear. Can you please tell again? Hello? It is very classical that at this point, if the patient complains of pain, anybody? Okay, so this is nothing but cluneal nerve entrapment. So as you can see here, at this level, around 7 to 8 centimeters lateral to the midline, you can see the cluneal nerves which are passing on the iliac crest. So whenever there is entrapment of these nerves, it can actually mimic sciatica. Few people can have leg pain as well. Okay, so this is called as cluneal nerve entrapment. Coming to a little bit of introduction. So this was described by Robert Main. So these are the cutaneous nerves which have a neural contribution from T11 to L5 dorsal rami. So that is why they mimic sciatica. So there are three nerves, cluneal nerves, that is superior cluneal nerve, middle cluneal nerve, and inferior cluneal nerve. So superior and middle supplies the gluteus medius and maximus. The inferior the origin of it is posterior femoral cutaneous nerve of the thigh, that is S1 to S3 it is derived from, and it innervates the inferior region of the buttocks, the lateral anal region, and lateral labia majora. So any pain in that region, we always have to keep this as a differential diagnosis. So, So this, as you can see, I've just mentioned how the cluneal nerves travel from the dorsal rami to the iliac crest. So it originates from the dorsal rami, passes through the erector spinae and through the psoas major muscle and other paraspinal muscles and latissimus dorsi, and finally reach the iliac crest. And whenever it comes above the iliac crest, there is an osteofibrous tunnel which is formed by the thoracolumbar fascia to protect them. So whenever there is an entrapment within the osteofibrous tunnel, so this results in entrapment symptoms. So coming to the etiology, etiology of entrapment is, it can be trauma, traction, or repetitive movements of friction, or in golf or cricket players, or whoever is wearing a tight jeans pant or a belt at the site, because it is exactly, the location is exactly at that site. And in Parkinson's disease, because of the rigidity, And surgical surgical causes can be any spine surgery can lead to fibrosis at that region, and because of the incision and the suture, so there can be fibrosis at that region or injury to the nerves as well. And iliac crest grafting, which is most common cause of cluneal nerve entrapment, that is, whenever orthopedicians take a graft from the iliac crest, so the post graft, that is, immediately they will not have any, patients will not complain of any pain, but over a long time they can come with same entrapment symptoms, that is back pain going to the leg, and all these symptoms can be so in history we have to always ask about any past surgical histories, like any surgeries done in the past have to be asked. So posterior hip surgery is also one of the cause, and decubitus ulcer surgeries, because the area is that, so nerve injuries can happen. So presentation, they can present with only low back pain, or they can present with only leg pain, or low back pain and leg pain. So it usually mimics radiculopathy. So features of superior cluneal nerve entrapment is intermittent claudications due to worsening of low back pain during walking. So aggravating factors are extension, because it's an entrapment. So extension, bending, or any movement at the level, at the spine level, walking or rolling can cause aggravation of the symptoms. And in case of middle cluneal nerve, it is short and long periods of standing or lumbar flexion. Same thing, prolonged sitting, rolling, or walking can aggravate the symptoms. So there's a short video how the patients come to you. Usually they hold that region and walk. So how's the gait? So whenever we see a patient in OPD, gait is very important in cases of hip pain and spine, the lumbar pain or the back pain, because it tells a lot about differential diagnosis and sometimes classical of diagnosis. So this is the superior cluneal nerve gait pattern. So they always push their hands down to the iliac crest because it gives them relief. And other is they can bend a little forward and push the hand and keep the hands at the level of iliac crest and push it. So this can cause relief of the symptoms. So I'll just play the video. Sorry. Is it playing?
No, it's not.
Sorry. So usually they walk in with this. I'm sorry, this video is not playing. But they usually walk with little bit of forward flexion. And this can, whenever you provoke it, like ask them to bend forward, the pain increases. So they also complain of leg pain when they bend forward because of the restriction at the osseofibrous tunnel. Sorry, this is not playing. So what all differential diagnosis we can think about is, one is, one is the vertebral fracture. Any lumbar spine disorders like vertebral fractures or spinal canal stenosis. The only thing is the bending gives relief in spinal canal stenosis, but in cluneal nerve entrapment, the bending increases the pain. And facet joint disorders can also be one of the differential diagnosis. There is thoracolumbar junction syndrome, also called as Main syndrome, where there is pain at the distribution exactly at this T12 or L1, which is relieved by the diagnostic facet injection. So this is because of the entrapment of the medial branch of superior cluneal nerve. This also sometimes is called as the Main syndrome. There is sacroiliac joint disorders which can mimic this, and iliolumbar syndrome, where there is unilateral low back pain. So as we saw earlier, and certain myofascial pain syndromes like paraspinal myofasciitis or some trigger points in the paraspinal region can mimic this. Gluteus medius or muscle pain or compartment syndrome can also result in, because it is located at almost at the same region. And piriformis syndrome can also mimic the sciatica, like back pain radiating to leg pain. And inferior cluneal nerve, as I've told, the pain in the ischium, whenever they're sitting, you can, because it supplies the lower anal crease. So sitting causes pain because it is at the ischium, it supplies in the lower part. So sitting can cause pain, which is relieved by local anesthetic diagnostic injection. This is one of the diagnostic injection which we can give to identify the condition as well. So there are certain diagnostic characteristics of cluneal neuralgia. Like if you see them, then it is definitely cluneal neuralgia. So one is physical examination. So symptoms of entrapment may be reproduced by palpating at that region, like 7 to 8 centimeters outer part of the midline or lateral to the midline. So hyperextension or lateral bending to side and opposite side, the complaints can be there, like pain can be there. Diagnostic injection is one thing which is very helpful in cluneal nerve entrapment. So if feel there is cluneal nerve entrapment, we can always give a diagnostic injection and confirm. Maybe 1 cc of local anesthetic, because if you're using ultrasound, then you're clear where the nerve is, and the entrapment is the nerve is also very small. And if we give only 1 ml, then it becomes diagnostic. Otherwise, there is spread to the.
तुम्हारा एप्पल आईडी का पासवर्ड क्या है?
So ultrasound is also one of the, what we can see in ultrasound is the nerves appear small, hypoechoic structures just inferior to the border of iliac crest. And X-rays, this is non-specific actually. To rule out other causes, you can always get an X-ray and MRI done. And CT scan may show like a bony groove at the osteofibrous tunnel. And sometimes if there is a radiculopathy, so electrodiagnostic studies can also be done only if the MRI is showing some lumbar, spinal canal stenosis or any other features of nerve pain or neuropathic pain. So management is conservative management. There is pharmacotherapy here. Anti-neuropathic medications have to be given along with the NSAIDs because it's a nerve pain. So, and physiotherapy can also be done. Hot pack compression and stretches and strengthening exercises have to be taught to improve the pain. And certain interventions, as I told, diagnostic block can be done using ultrasound guidance, which acts like a diagnostic injection as well and a therapeutic injection as well if we add a little amount of corticosteroid in it. And if it is if the fibrous tunnel is very thick and the diagnostic injection has relieved, but it is still causing the entrapment and the neuropathy features, then we can always suggest surgery. So here, so whenever this is just a pathway for cluneal nerve pain diagnosis and management, like what all can be done. So one is whenever there is a palpable trigger or tender points in the upper buttock region, which is not responsive to physiotherapy, so then we can think of a cluneal nerve block, whether this can relieve the pain temporarily or not. And if we have to do a spine instability test, so if this is positive or not, so this has to be done to see whether the pelvic alignment is there or not. So if the cluneal nerve block relieves the pain temporarily, then we can always do radiofrequency ablation of the cluneal nerve, which relieves the pain. And also prolotherapy of the thoracolumbar fascia and the lumbopelvic ligament can also be done along with rehabilitation. So if the cluneal nerve block relieves pain permanently, then we can directly go ahead for rehabilitation. So this is the there's another method, that is the peripheral nerve stimulation. Peripheral nerve stimulation of the superior cluneal nerve. This is on the iliac crest. So ultrasound scanning, there are two methods of, I'll just be giving a brief about how to scan the cluneal nerve. So there are two methods. That is, one is above the iliac crest and below the iliac crest. So above the iliac crest, if we are scanning, so as you can see here, this is above the iliac crest and this is below the iliac crest. So above the iliac crest, when you're scanning, you get skin, subcutaneous tissue, the thoracolumbar fascia, okay, and latissimus dorsi and superior cluneal nerve. And medially, you will have intercostalis, that is lateral muscle of erector spinae, and laterally you will have quadratus lumborum muscle and middle layer of the thoracolumbar fascia. And below the iliac crest, you will have just as it is superficial, you just get the skin and subcutaneous tissue, the superior cluneal nerve, and the gluteal fascia and the gluteus muscles or the iliac crest. So as you can see here, whenever you are scanning above the iliac crest, always start from lateral abdominal wall and then move medially. And another technique is start from the iliac crest and move up. So if you're starting your scanning at the iliac crest or below it, start from PSIS, move up or laterally, up and laterally. That is keep a bony structure as your friend. For example, PSIS at this site. Other thing is you can start always from the iliac crest and move down. So you have to always start from the bony prominence, except here we can also start from the lateral abdominal wall muscles. So as you can see here, so this is the method. Start from the PSIS, go up and a little laterally. You can see here, as you can see here, so this is the fat tunnel. Okay, this is the thoracolumbar fascia, erector spinae. This is the iliac crest. So this is the hypoechoic fat pad. So if we are giving injection, it has to be between the thoracolumbar fascia and the erector spinae. So there lies the superior cluneal nerve. So here. So there's another technique. So from lateral, you're coming to medial. As you can see, here it is this is the thoracolumbar fascia, and this is the erector spinae, the outer part of the erector spinae. This is the thoracolumbar fascia, and this is the latissimus dorsi and the internal oblique. Here the abdominal muscles come. So here the target is between the thoracolumbar fascia and the erector spinae. So here the drug has to spread in between them. So when it's a plain block also, so that is why using ultrasound for diagnostic injection is necessary, because since it's a plain block, you have to be there at the site. Prolotherapy is also one of the options. So this has been mentioned in few papers as well. Spinal ligament is targeted, which improves the lumbopelvic stability. And the subcutaneous neural prolo, wherever there is an entrapment, we can always do a subcutaneous neural prolo for the release as well as for the regeneration of the nerve. So the take-home message is understanding the uncommon presentation of hip pain is crucial for accurate diagnosis and effective management. Usually, it's very difficult to pick all of them and to treat also, few of them to treat as well. So timely recognition of these uncommon etiologies can significantly impact the patient outcomes. Guiding the appropriate imaging studies and interventions and if needed, we have to refer them to a surgeon. So while most of the cases are attributed to osteoarthritis of hip, we must remain very vigilant for atypical presentation that may signal underlying pathologies and treat them in the earlier or the initial stages, or guide them if it is in the later stages. If they come, guide them the correct manner of management. By thorough history and examination with necessary investigations, it can be diagnosed and targeted therapy can be given, which can improve the quality of life of the patient. Thank you.
Thank you very much, Dr. Shubha. That was an excellent presentation, as always. And now I'd like to open the floor for the questions. If anybody has any doubts, you can unmute yourself and you can ask, or conversely, you can message in the chat box as well, whichever feasible. Okay. So Shubha, I'll start off. Basically,
Okay.
I think, yeah. Now you spoke about cluneal nerve entrapment, right? And you
Yes, sir.
spoke about the interventions as well, correct?
Yes, sir.
So for that, after an intervention,
Mhm.
for example, the patient comes back, right? Even after a prolo or after a steroid injection, then is there a definitive treatment there for a more prolonged duration of action?
Radio frequency can be done. So radio frequency ablation of the nerve can be done.
Good.
Yes.
Yeah. So what radio frequency would you want to choose? Conventional or pulsed?
Since it's a since it is also supplies the muscles, we choose pulse radio frequency ablation, sir.
Okay, good. And what would be the pulse radio frequency ablation parameters?
For 4 minutes, we do the pulse. I mean, the frequency will be,
Yeah.
the temperature will be around 42 degrees Celsius. Then
Yeah.
you have to do it for around 4 minutes.
Correct. Correct. Good. So
Okay.
basically, there is a variation. I mean, the duration, as per the recent studies now, what they're telling is keeping a longer duration of action also. I think, I mean, duration of the lesion
Yeah.
is producing good results. 8 to 10 minutes is also being kept nowadays. And also in one of the recent conferences where I had attended, so they told that increasing the voltage also makes a certain difference, right?
Oh.
So ideally, the voltage is one thing which is preset, right? It is there in a machine, but some machines have the functionality where you can change the voltage. So if that is possible, then you can always increase the voltage to get best results. Not
Okay,
only
sir.
for peripheral nerves, but even for other larger nerves like spinal nerves also, DRG also, if you're doing, you can
Okay.
follow this particular thing, right?
Okay. Okay, sir.
Yeah. Hmm. Anybody, are you having any doubts you want to ask Dr. Shubha? And again, about the cluneal nerve itself,
Yes,
for a
sir.
long period of time, it was assumed that cluneal nerve entrapment is actually, it is something like, it is not there.
Not
Right?
existing.
It is a non-existent thing.
Mhm.
Again, with the research and everything, they've come to a conclusion that yes, it is definitely an entity and very difficult entity because the hip region, especially posterior hip, I believe hip region is like a Pandora's box, and it becomes very difficult to understand what exactly how to manage these particular conditions, let alone diagnosis. First you diagnose and then you manage.
Yes, sir.
Dr. Shubha, any role of RFA for conditions like snapping hip syndrome or femoroacetabular impingement? Anything? Have you read or seen anything about it?
It can be done if the diagnosis is regarding the nerve, it can be done. I've read it somewhere, but I'm not sure about this. I've not.
Yeah, because I'm sure you would have seen patients with avascular necrosis of the hip, right?
Yes.
That another one condition. I think we had planned to keep it, but then it would have again extended the duration, so we decided to drop it. But avascular necrosis, as such, even for that, even after surgery,
Yeah.
get
Any
patients.
osteoarthritis, since it leads to osteoarthritis of hip, we can always do a radiofrequency ablation for the articular branches, sir.
Correct, correct. Yes. So in the chat box, I'm seeing only people appreciating your talk, Dr. Shubha. Very informative, excellent presentation. Excellent presentation again. So I would say that this was a very necessary topic, and I'm very happy that Dr. Shubha volunteered to present on this particular topic. This topic, as such, is as I said, really a Pandora's box because it can make pain physicians put their thinking hat on regarding what could be the diagnosis and everything. And as all of you have put in the chat box as well, definitely it was a very good presentation. So I'm very happy that they say that whenever a student does really well, it is the teacher who feels the maximum happiness along with a small sense of pride as well. So I'm very happy that Dr. Shubha did her fellowship under me. She is my student, I can always say with pride. And very, very happy to see this presentation go so well. Thank you very much, Dr. Shubha.
Thank you so much for giving me this opportunity. And in fact, you have only taught me clonial nerve entrapment. And I had taken advice from you regarding the femoroacetabular impingement as well, since it was something new, because even for me, I was not able to understand if we have a role in it or not. So thank you for your guidance, sir.
You're welcome. I would say that the galaxy of pain physicians, doctors is increasing. And definitely Dr. Shubha is one of the most brightest shining stars in it.
Thank you so much, sir.
Thank you all for attending today's webinar. We will be putting up this recording as well on our YouTube channel. And stay tuned for the next month's topic we will be announcing. And one more thing is our workshop is has been announced. It's on the 1st of December in Bangalore. And this time we'll be focusing on ultrasound of the entire spine. Okay. Along with live interventions as well. The registrations have started. Early bird registration is going on. So if anyone is interested, kindly feel free to contact me. Okay. Thank you all for taking out your time on a beautiful Sunday morning.
That's a great initiative by you, sir. Thank you so much.
Thank you so much. Thank you so much, Dr. Shubha again.
Thank
Bye.
you. Bye.